All right, guys, we are almost there. So thanks for spending time with me this semester. And you really are almost done. This is our final lecture, and there will be a final quiz. And let me get through some paperwork type of things here. So make-up quizzes. If you have missed any quiz or quizzes along the way, this is your one chance to make everything right. To redeem yourself, to get the grade that you want out of this class. If you happen to miss any of those, would you send me an email that includes a date, the quiz that you need open, and the time frame that you'd like it open. For example, I'd like it open on December 10th from 9 in the morning until 9 at night, and I will open it up during that time period. So this is like the library. If you borrowed a book and forgot to take it back, and they once in a while have that, hey, all bets are off, make things right, this is your chance to do that. So you have to show the initiative, though, and show me that you listened to this video by knowing to do that. You have to send me an email that provides quiz number, the date that you want to take it, and the time range that you need to open. And like I said, even if you've missed more than one quiz, I would allow that. This is your chance to make things right. The only catch is you only have one opportunity instead of two like you could have taken on the other ones. The final quiz is going to work just like your weekly quizzes. It's going to open today. You're going to have a week to complete it. The deadline will be posted with the quiz, so you can always check that way, is just look at what is the posted deadline that's included with the quiz link. The final quiz is just 10 questions in length, so it's not even a longer quiz like your midterm was. And there are 4 additional extra credit points up for grab, and those are in the form of 2 2-point extra credit questions. Grades will be posted as quickly as possible, so everyone will be done the beginning of finals week, and I should have grades posted easily by the end of finals week. If you have any problems accessing your quiz, or you need further instruction on how this final process will work, you're more than welcome to contact me. So let's get started, and the advantage is this is even a shorter lecture. So common symptoms are some things we talked about in this class, and let's see if you can kind of go through this list. So I'd like you to spend just a little bit of time as we go to each one of these. You tell me what you think is the most common thing that we should consider when we hear that. And we talked about ruling in or ruling out, or the process that we use of starting from the most or least invasive to most invasive in most cases. So right upper quadrant pain, do you remember what that goes with? Right lower quadrant pain, do you remember what how that would distinguish it? So right upper quadrant pain, we're thinking gallbladder typically. Right lower quadrant pain is what we usually have as a symptom for appendicitis. For upper quadrant pain and for appendicitis, we would probably, for both of these, maybe start with an abdominal ultrasound. It would be non-invasive. It would help us see that inflamed appendix, or it would help us see that the gallbladder, maybe that there are stones that are present. An X-ray is probably not going to be very helpful in both of these, but it is non-invasive as long as we don't use contrast, and so it might also be a starting point. But I'm guessing in most cases we're going to get an ultrasound, and we're probably going to start with a complete blood cell count, because if I do have right lower quadrant pain and I have appendicitis, that would cause my white blood cell count to be elevated, and so a CBC with a differential would be a good thing to get. Stiff neck, what does that make us think of? Can you remember back to those discussions we've had in the previous lectures? So with stiff neck, I'm probably dealing possibly with meningitis. Heavy feeling in chest or left arm or jaw pain. We talked about how women, this might present differently, more as back pain. It can also present that way in males. So if you have those feelings, if you think it might be indigestion, it's always best to get it checked out. And heavy feeling in the chest, left arm, or jaw pain, that is usually indicative of a myocardial infarction. Dizziness or fainting, boy, this is kind of a non-specific one. And when we talked about this in our lecture, it could be anything from electrolyte imbalances to a heartbeat that's too quick, like that paroxysmal tachycardia, where it comes and goes. Maybe I can feel the fluttering in my chest. So maybe if you ask me questions, we could get a little bit closer to this. What had I just been doing? Had I run a race and I might be dehydrated? Have my electrolytes abnormal? Or is this a situation that sounds like, hey, I felt that fluttering in my chest before I had this dizziness or fainting spell? It could be panic attacks. It could be diabetes issues could cause dizziness and fainting because the brain uses 1/3 of that glucose in our blood. And so that could be a problem with that. Flank pain. So the flank was found by putting your hands on your hips with your thumbs forward. So your fingers are aligned along your back, and the area that they're covering is considered your flank. We said usually it would be one-sided flank pain, and when you have flank pain, we think about your kidneys. So did you have an injury to a kidney? A lot of us are watching football this time of year. Did somebody take a hit to that area? Have they had blood in their urine? Is this kidney stones we're maybe dealing with? Or maybe a nephritis where they have infection or inflammation in the kidney. Numbness and tingling, this could be as simple as you've hyperventilated, but it could also be tied to electrolytes or neurologic disorders. Do you have a pinched nerve? So we might get to the point where, again, we might start with just by questioning you and then move to more invasive procedures. One of the most invasive, if we think it's a pinched nerve, might be that myelogram. And we said a lot of those are being replaced by detailed studies with MRI, or in some cases that helical or spiral CT with contrast media. If I have a headache, again, we're dealing with a non-specific symptom, so we'd ask you more questions and hopefully start with least invasive to then most invasive as appropriate. With headache, it could be a brain tumor. It's not a tumor. It could also be that you have high blood pressure, so it could be just as simple as doing a blood pressure test. It could be that you have some cardiac issues, like an aneurysm or something like that. So headache can be nonspecific. Headache could be caused by things like glucose abnormalities, dehydration. So there's a whole bunch of things that could go with this and would require further testing. Dyspnea or orthopnea. So dys in front of a word means difficult, and pnea is what we refer to, like if you, I bet you've heard of the term apnea. Well, dyspnea is difficulty breathing, and orthopnea is positional breathing. So I breathe better if I sit up in my recliner chair, or if I sleep with 3 pillows. That is orthopnea. And somebody who has dyspnea or orthopnea, we'd probably start with a chest x-ray, maybe a blood gas, an arterial blood gas to check their carbon dioxide and oxygen levels. We might have them do a walking test, and we look at what happens to their oxygen saturation as they exercise, which could be just as simple as walking. Excessive thirst or hunger was really a classic symptom for diabetes. And as the body does not have insulin to help glucose move into the cells, those cells basically tell the brain, hey, we're hungry. We need that glucose, or we need that substrate to help us kind of survive here. So excessive thirst or hunger usually is a red flag or a common symptom associated with diabetes. Slow growth or slow onset of puberty, and we could also put quicker growth or quicker onset of puberty in front of that. Usually that makes us think back to those endocrine glands such as the pituitary gland and possibly some of the endocrine glands like the ones that sit on top of the kidneys, so the adrenals possibly. So we had that mechanism where the parathyroid and the thyroid and the pituitary and the adrenals in a lot of cases have hormones that kind of intertwine and act on all of those together, or at least combinations of those. All right, at the very beginning of classes this semester, we had the complete blood cell count. And so this person's had a CBC done at a health fair, and their monocyte count was elevated. You can see the normal range here is 0 to 12, and they had a 15.8. Everything else was fine. So what is the significance of this reading? So when we did the differential, we talked about, we're looking at specific types of white blood cells. Do you remember what caused lymphocytes to elevate? The most common type of infection that we think about when lymphocytes are elevated? Or is that way too far back? So you could just look. You had the lecture titled White Blood Cell Count. And so you could go back to that one. Lymphocytes, really quickly, were elevated if there's a viral infection. Neutrophils, the most common type of white blood cells, are usually associated with a bacterial infection, or most commonly associated with bacterial infection. Monocytes were elevated with a fungal infection. So maybe we have someone, and this is not, and I've mentioned this previously, it's probably not like a severe case of athlete's foot. This is that you can actually get fungal infections in your bloodstream. It could be that you have fungal infection in your lungs. So there are different places that fungal infections could exist. And that is usually the most common reason that the monocyte count is elevated. Now, if they said all the other results were fine, so their total white blood cell count wasn't elevated, what is the significance of this reading? So we said it's pretty rare that we do something just on the basis of one laboratory test alone. So we would talk to the person, we would evaluate the person, we might do further testing, and it may just be that we say, here's the most common reason, and start to look from that point. And it may be that it falls down to that bell curve that we talked about that very first lecture of there will be people who are normal who do fall outside of the normal range on a laboratory test. But to make laboratory tests useful and of benefit to the whole, we have to make some point where we say it's normal to have a monocyte count, for example, between 0 and 12. All right, what is this? When we had these pictures that look like this, boy, did you catch it quickly there? We had a KUB or an IVP. So kidney, ureter, and bladder film, because that x-ray does include this area of the body. Kind of the pelvis area. We said a KUB x-ray might be done if we had someone who had a suspected bowel issue or they have unspecific intestinal pain, or we want to look at the kidneys for stones, remember, because 90% of those kidney stones were made of some sort of calcium. So we could do a KVP film, KUB film, kidney, ureter, bladder, or we could do the IVP, intravenous pyelogram. And remember the difference there is we're going to take a KUB film, but it's going to be that they had an injection of contrast media into a vein, intravenous pyelogram. And in this case, can you see the dye that's outlining, in this case, the drainage port of the kidney? And you can see it coming down those ureters into the bladder. So this is an IVP. And the way I know that is I can see this contrast media. Normally on an x-ray, I don't see bowel or soft tissues of any kind unless there's fluid in them. And in this case, the fluid here in the bladder is dye. Or if there's air, I can see these intestines. Can you see this little loop of intestine here that has air in it? And so I outlined it. But normally soft tissues, I don't see, right? There should be a liver tucked up under here. Do you remember that? No, over here. We talked about how when you have an x-ray, it's as if the person is facing you. So this would be their right side. This would be their left side. Boy, it even caught me there for a little bit. So liver would be on this side, and all we see is this mass up here. So this is an IVP film because I can see the contrast media. Oh, those dreaded blood gases. So do you remember the process that you took? And this one's just a piece of it. It doesn't include the oxygenation piece. So we looked at the pH and we determined, was it on the acid side? Was it less than 7.35? Or was it on the alkaline side? Was it higher than 7.45? So in this one, we're higher than 7.45. That would be an alkaline pH. Then we go to the CO2, and the normal range for CO2 was 35 to 45. So this is actually within its normal range. So I would put normal there. I would move to the bicarb, or we've gone to the respiratory system. Now we're going to the metabolic system by looking at the bicarb. Normal range for bicarb for an adult is 22 to 26 milliequivalents per liter, and this is 31. So I have a bicarb that's elevated, and I remember the arrows for bicarb. When bicarb goes up, the pH arrow goes up. It moves the pH in an alkaline direction. So the cause of this pH that's alkaline has to be the bicarb. So I have a metabolic alkalosis. Now I need to look and see if there's compensation. And to do that, I look at the other parameter. And I say, has it moved outside its normal range? If the answer is no, I say uncompensated. So the answer to this question, this interpretation, is it's uncompensated metabolic alkalosis. To make it partially compensated, this would be moved outside its normal range, but it would not have brought the pH totally back within 735 to 745. So partially compensated would be the other parameters moved outside its normal range, but it hasn't brought the pH completely back to 735 to 745. If it's done that, then it would be fully compensated. So I could throw out respiratory alkalosis because it wasn't the CO2 that caused this pH change. When CO2 goes up, pH goes down. When CO2 goes down, pH goes up. This is a normal CO2. So the correct name was a metabolic alkalosis uncompensated. How about this one? Can you try that process? So pH, the normal range was 735 to 745. Will you answer to your computer or write it down on a paper or answer it in your head? Is this an acid pH or an alkaline pH? 735 to 745 is normal. Now go to the carbon dioxide level. And the label on that would be millimeters of mercury or torr. Normal range is 35 to 45. So would that change in pH here cause the change in CO2 here, would it cause the pH to move in an acid or an alkaline direction? Remember the arrows of CO2 and pH? Then we look at the bicarb. The normal range for bicarb is 22 to 26. So would that cause, if I just look at the bicarb all by itself, if I have a bicarb that's higher than normal, will that move the pH in an acid or an alkaline direction? So the way I approach these, I would have acid here, I would have acid here, and I would say this change in bicarb actually moves the pH in an alkaline direction. So I would write alkaline here. To name the disorder, find which one matches it. If they both match, it's called combined. But in this case, I only have a CO2 that's caused my pH to move in an acid direction. And so it's a respiratory acidosis. So I could quickly go through and eliminate the ones that don't say respiratory acidosis. Next, I look for compensation. Has the bicarb moved outside its normal range of 22 to 26? And I would answer, yes, it has. And it is moving in a direction to try and compensate. So I know there's partial compensation. To determine if it's partial or complete, I look back at the pH. Has the pH returned to its normal range of 735 to 745? And the answer is no. That makes this then a partially compensated respiratory acidosis. The respiratory system broke it. The kidneys are trying to fix it by saving bicarb, but they haven't been able to save enough to bring that pH back in its normal range. And probably what this person really needs is somebody to intubate them or give them a treatment with that will help them blow off that carbon dioxide, maybe put a tube in their throat and hook them to a machine that will help breathe for them for a while. All right, what is this? Well, it says hematology. That would be a blood report. And I look and see. Here's a white blood cell count and neutrophils, lymphocytes, monocytes, red blood cell, hemoglobin. Well, this is a CBC, and I've also got a SED rate on here. So I really have two tests here. I have a CBC and a SED rate. And if you look through, you've got the normal ranges over here. So let's just go through quickly and pick out the ones that are abnormal. So there's little evidence of infection or inflammation based on just the white blood cell count total because it's within its normal range. The neutrophils are within their normal range, and this lab is reporting percentages rather than the numbers, but I could figure out the numbers just by doing 60% of 11,000, so 0.6 times 11,000, and I could get the numbers. However, it's just mathematical manipulation. The lymphocyte count is within its normal range. Do you remember this would indicate bacterial infection, viral infection, fungal infection, allergic reaction. So eosinophils within their normal range, monocytes within their normal range. Red blood cell count. Oh, here's a problem. So let's figure out if this is a male or a female patient. That's something we discussed. Based on the hemoglobin level being reported as normal of 14 to 17, is that a male or a female? Remember that usually females have lower ranges of normal. So 12 to 16 or 12 to 15 is a female, 14 to 17 is a male. So this is a male patient. I can know that just by looking at their hemoglobin. Their red blood cell count, here we are reminded that white blood cells are present in the 1,000, red blood cells are present in the millions. We've got a low red blood cell count. Do you remember the terms that we could use to correctly indicate that and look really fancy and smart? So in most cases it would be reported as anemia. It would also be correct to do erythrocytosis, erythrocytopenia. So we have a low red blood cell count, but the most common term is probably going to be anemia. Because the red blood cell count is low, we can almost guarantee that the hemoglobin and crit are going to be low. And if you don't remember that reason, go back and review lecture 2. So those things trend each other. If I want to estimate the hemoglobin from the crit, I take the hematocrit divided by 3. If I want to estimate the hematocrit based on the hemoglobin, take the hemoglobin times 3. And there are times where maybe you just get one of those, like the hemoglobin. I have some red blood cell indices that could help me identify the cause or type of anemia. This is saying the cell volume is above normal. The amount of hemoglobin on each cell, the cells are beefier than they should be, but I don't have as many as I should. So maybe this is just a regular anemia, maybe due to hemolysis. Maybe there was a blood incompatibility, or maybe it was due to hemorrhagic anemia. I just had blood loss. The platelets are okay. So the platelets and white blood cells, which are produced in the bone marrow, are okay. But the red blood cells, which are produced in the bone marrow, are low. That would lead me to believe that I have a problem then with either a diet, right? It took iron and it took vitamin B12 and B6 to make red blood cells. So maybe the person's either lost blood cells or they're not producing them as quickly as they should. Something's happened to those. Then we go to sed rate. So here's a different test, and sedimentation rate looks for inflammation or infection. And we talked about this one, that red blood cells normally don't stick together very much, but if they become inflamed or infected, they have a tendency to stick together. And the sedimentation rate is just like the name sounds. We're going to take anticoagulated blood and look at how quickly those red blood cells settle out. So we took the whole blood, which has solids and liquids. The main solid would be the red blood cells. And we see how quickly do those settle out. And with this one, it was within its normal range, but an elevated sed rate usually means infection or inflammation. As the red blood cells have those changes occur, they become more sticky and settle out quicker. And we said also autoimmune disorders, a lot of times they'll use the sedimentation rate maybe to determine if you need to be on more medication or less. Well, here's the blood chemistry. What is the name of this one? I've got a glucose, a BUN, a creatinine, a cholesterol, and albumin. Boy, that's kind of a hodgepodge of things, huh? I've got a test that looks at the liver. I've got some tests that look at the liver indirectly by its processes, what it does. Bilirubin, that's something the liver's supposed to get rid of. An LDH, wow, that one was liver, kidney, kind of not as specific. I've got albumin. That's a protein that the liver makes that's impacted by diet. I've got cholesterol, which looks at my risk for heart disease. I've got BUN and creatinine, which were the renal profile or the kidney function tests. So this looks like a chemistry profile. And if I counted the number of tests, 1, 2, 3, 4, 5, 6, 7, 8, 9, I could call this a Chem 9 or a chemistry screen. So what's normal or abnormal with this patient? Well, their glucose is within its normal range. Their blood urea nitrogen is within its normal range. So go through each one of these and let's find what's maybe wrong with this patient. Their cholesterol is actually low, and in most cases that could be a really good thing. But your body does need a certain amount of cholesterol to make hormones and to repair body cells. So you could actually have too low of a cholesterol. People go on cholesterol lowering diets, but no doctor will ever tell you to eliminate all cholesterol from your diet. I don't know that this level is not extremely low, and so it's probably going to be pretty much ignored. Let's go to albumin. All the proteins are okay. Look at this LDH though, 624. And so LDH could be cardiac, it could be renal, and it could be the liver. Well, if it was liver, there could be changes in the bilirubin. And I do have an elevated bilirubin, both the direct and the indirect, or the total bilirubin count is what I've been given. So I know that both of those would be elevated. So if my bilirubins are elevated, that could mean that either red blood cells are being destroyed because biliverdin becomes bilirubin and it's the waste product of red blood cell destruction. I have this elevated LDH though, and then I go down here and I have an AST. Do you remember this one? Is this the one that's specific for the liver, or was that ALT? Do you remember we could use these initials, not that that's what they stand for, but I shared with you how I use ALT. I use the L in it to remind me that that one's the liver specific one. This is the generic one. So if this isn't elevated, I really can't rule out the liver. These have a tendency to kind of point me at the liver. So at least one thing I'd have to examine further, I'd like to see that ALT, because if it's normal, then I know I'm dealing with either kidneys or cardiac. But two things, the LDH and the bilirubins, are kind of pointing me in the direction of the liver test. All right, liver function tests and bone profiles. So bilirubins, this person's within its normal range. I bet you can tell pretty quickly the ones with up arrows and down arrows that are highlighted in red are the abnormal ones. So the person has an elevated ALT, but a normal ALP. And this one is not AST, this is ALP. Remember, we used L to Q as to liver and P for placenta. The other thing that affects ALP commonly is bone cancer, like Paget's disease, things like that. ALT, this is one that's liver specific. So we do have some sort of involvement of the liver. Usually we say the higher the level of the enzyme, the more damage that's been done. But in cases of chronic kidney disease or liver disease where you've already damaged so much tissue, there's not very much to respond by releasing that enzyme. So it's probably not a good rule in cases of chronic liver conditions. Our albumin is low, and the liver does process this protein. So maybe it's not producing those proteins like it should. Gamma GT, GGT test, and that one can be elevated if there's liver damage or kidney damage or cardiac damage, maybe liver and kidneys more specifically. We have a calcium level, and then a phosphate level, and our CRP level. So we know that the liver's involved right here. And even though the bilirubin was within its normal range, this ALT being elevated tells us there's liver involvement. Now, it could be something as simple as a person who drank some beer before they had their tests done. And as the liver breaks down medications or alcohol, it could have a little bit of damage and be elevated like this. But we have this albumin that's low too. So is this a person who doesn't have an adequate diet and so they don't have the things they need to make the protein? Albumin. GGT is elevated. That makes us think, hey, that could go with that liver damage. And then we get to the CRP. And CRP is a test, C-reactive protein. It was one that we talked about when we talked about cardiac function or other tests that may be used to look for inflammation or infection or screen for those. So CRP levels elevate when we have infection or inflammation. And in most lab reports, it's supposed to be a very low number. Do you see that this one's elevated? It's not really specific, though. It's not going to give me the exact answer of, yes, it's inflammation or yes, it's infection. But maybe if I combined it with these things, maybe I do have some sort of hepatitis, an infection or inflammation of the liver. All right, what is this? Well, I have a chest x-ray. And you remember that the lungs should be dark and air-filled. Air-filled things are going to be black. Things that are dense are going to be more white. So we have a liver over here that's pretty dense. Well, I have this big thing over here that shouldn't be present in the lungs. The lungs should look like they do on the person's left side. So I have some sort of right middle lobe probably process here affecting the lungs. So I have maybe some sort of consolidation that could be caused by pneumonia, could be a tumor that's causing an airway to be blocked and not let air to get there. You can kind of see some little nodules here. And if I have circles or nodules like that in the mediastinal area, there are blood vessels and things that are large enough to give me that appearance, but not out here. I shouldn't have big blood vessels out here. So those are probably nodules. So this person needs some more follow-up, maybe a biopsy, maybe a bronchoscopy to go down here and see if there's something they can relieve to let air back into that area, or a tumor that they could maybe biopsy or move out of the way, or some secretions that they could flush out of the way when they do the bronchoscopy. All right, here's a person who has a normal CBC, a normal sodium, a normal potassium, a normal chloride. So 135 to 145 for sodium. This was your electrolyte lecture. Potassium 3.5 to 4.5. Chloride 95 to 105. Bicarb 22 to 26. Plasma glucose is usually the highest level should be 110. So this person does have an elevated glucose, but it says it's a random one, not a fasting one. So that may be a little bit elevated just because you just ate before you had this done. So it'd be important to know, is it a fasting glucose? Is it a fasting blood test, or was it like this one was a random? Their BUN, creatinine, and liver enzymes were normal. So their liver shouldn't be abnormal. Their kidneys shouldn't be abnormal. But they do have +2 glucose in their urine, +2 protein in their urine, 4+ leukocytes in their urine. And normally the urine should contain no glucose, no protein, no white blood cells. There's a little bit of blood and a little bit of ketones. And remember, ketones are a product of metabolism of fats. So good thing if I'm trying to lose weight, but not a good thing if they're accompanied with a glucose level that's elevated. So the bad news is we're probably dealing with some sort of early diabetes or pre-diabetes because of these things. We may have some sort of infection. We have white blood cells present, but they could just be there because of damage to the lining. And we have a little bit of blood there, so maybe we have a urinary tract infection going on too. The good news is it hasn't led to damage of the kidneys yet, and that could be a complication of diabetes that will come. So that's why it's important to diagnose diabetes and then try and keep tight glucose control. What's being done here? So the person's laying on their side. They've kind of been placed in fetal position, and we have a physician or a practitioner here who's prepped this area, sterile draped it, and they are doing a lumbar puncture. So lumbar puncture most commonly done to check for cerebrospinal fluid analysis, and that would be for meningitis. It could be as a part of treatment for cancer. It's a screening test. We'd look for cancer cells. It could be to relieve pressure. So it can be therapeutic or diagnostic when we discuss lumbar punctures. What's this procedure? Well, it's either a CAT scan, a CT scan, or an MRI, a magnetic resonance imaging. And to determine which one it is, I look at the detail of soft tissue. And I'm not seeing like extremely good detail. And I do have a CT or MRI coming up, so we'll see the difference. But if I look, the arrows usually point me to what's important. Well, this person's laying down. And I remember it's always as if the person's facing me. So here's their right side, here's their left side. And the left-sided organ here is the heart. Remember, your heart is primarily located on that left side. This is the top of their liver. So we've moved down to the chest, and we're just about to the diaphragm level. And we're picking up kind of this liver pushing up, but we're still within the chest cavity to pick up this heart. And you see it showing, here's the heart itself, and here's the lining of the heart. This is called a pericardial effusion. Remember, we could have pleural effusions where we had fluid, and we do have some here. Do you see this fluid here that's between the ribs and the lungs? So we have a pleural effusion, But the thing that's concerning for this patient is a pericardial effusion. And can you imagine every time that heart pumps, it doesn't have as much room to fill up because of this extra fluid on the outside surrounding the heart. So pericardial effusion, that could be drained by doing a pericardial window procedure, where they actually just make an opening in the pericardium and let that fluid drain. Or we can do a pericardial tap, where we put a needle there. But you can imagine the dangers of kind of putting a needle into a sac around the heart while the heart is still beating. And there are blood vessels that feed the tissue in the heart that could be damaged in the process. What is this? Well, this is an ultrasound procedure, and so we could look for blockages or in the form of clots, or we could look for tortuous or twisted blood vessels. We could look for aneurysms. They could be studies that are done on the blood vessels in the legs, either the arteries or the veins. So an ultrasound. Here's an MRI. Look at the detail of that soft tissue. You can see the muscles. You can see the meniscus. So this is a knee. So we've got the patella here, and we can see these structures, all this muscling and tendons and ligaments there. So MRI, you're going to have extremely good detail. The other thing usually about MRI is that we have more options as far as the imaging. That's not always true anymore with helical CT. We can kind of 3D reconstruct things. This was actually a family member who gave me their permission to put this on here. And it is the physical that they had done to receive health insurance, or excuse me, to receive life insurance. So let's see what those life insurance actuaries are looking at. Do you see down here under drug tests, they're looking for, do you take diuretic agents? And the reason they would look for that is people who have high blood pressure are usually on diuretic agents. Do you take beta blockers? Well, beta blockers are usually used for blood pressure. Co-nicotine or cotinine nicotine. So they're looking for someone who's a smoker to see, because those would elevate your risk factors for death, and so they would charge you more than someone who doesn't have cardiac disease or who doesn't use nicotine. Or then they also looked at illegal drugs like cocaine. Up here they tested the person's HIV status, and they said there was no antigen antibody reaction, meaning they hadn't been exposed to the antigen for HIV. They had a chemistry profile and went through each of those, and you can see how they easily in this lab report show you the ones that are elevated and the ones that are within their normal ranges. So this person had elevated cholesterol. They had elevated triglycerides, which usually mean you have increased risk of heart disease. They then looked at the different types of cholesterol, so high-density lipoproteins and low-density lipoproteins, and another one when we split those out into the lipid profile was the very low-density lipoproteins. This one is the protective one, and these ones are the harmful one. This is the harmful one. And then they usually do a ratio of the harmful one to the unharmful, or the unhealthy one. So high densities are protective against cardiac risk, but low density lipoproteins increase your risk. So this person does have a slight, well, an increased risk of cardiac disease based on these results. And when we look at their urinalysis down here, it reminds us that glucose levels should be negative. Protein should normally be negative or just have very small amounts. You should not have white blood cells in your urine. You shouldn't have hemoglobin or red blood cells in your urine. And so they're telling you, and we said there was a microscopic analysis of urine where we look for granular casts that indicate renal problems, Highland casts where it's kind of like that little jello mold of the inside of your kidney tubules. A specific gravity looks to see maybe, let's say I know you're going to test me for drugs today, or I know that you're going to perform my analysis for my life insurance policy, and I'm going to drink lots and lots of water to hopefully flush out anything bad that's in my system, like a drug, and that's a way to see, hey, did I just dilute my urine down? And that would make you suspicious for that. your temperature. So did you borrow someone else's urine? Isn't that an interesting way to look at that? And did you bring in your own sample? And then the creatinine and protein and creatinine levels, they've done those. So all of these were within their normal limits except this increased risk of heart disease, and so you might charge this person a little bit more for their life insurance. All right, so that's just kind of a quick overview of some of the types of topics that we'd covered. You are now ready to take that final exam. Remember, you can use your notes. I ask that you just don't have another person assist you with those questions. So thanks for spending your semester with me, or finding us on the internet if you found us on YouTube. And I will check out for now.